Welcome to the Campaign for Tobacco-Free Kids Cultural Conversation, Cuts and Consequences, Current Trends to Tobacco Control and Reducing Health Disparities. I'm Gustavo Torres, and I'm honored to guide today's conversation. For those of you who submitted questions in advance, if we don't have time at the end to get to all the questions, we will be sure to send out answers with the recap of today's conversation. As many of you know, CDC's Office on Smoking and Health, OSH, is the nation's only federal agency solely focused on preventing tobacco use, promoting smoke-free environments, supporting people to quit, and reducing health disparities. It delivers one of the best public health returns on investment. For every $1 spent, states save up to $55 in healthcare costs. OSH also runs the Tips for Former Smokers campaign, which has helped over 1 million people quit smoking and has saved an estimated $7.3 billion in annual healthcare costs, The agency's surveillance system, like the National Youth Tobacco Survey, are also indispensable in tracking trends and emerging threats. But these lifelines are under threat. The proposed elimination of OSH would dismantle the only dedicated federal funding stream for comprehensive state tobacco prevention and control programs, reduce support for quit lines, and end cost-saving campaigns like TIPS, and weaken surveillance just when we need it most. And that's why today's discussion is so timely. There's a long way for us to go, and our work isn't done yet. We still need each and every one of you to stand and band together to ensure that your voice is heard and these programs continue. So today, we'll hear from leaders fighting on the front lines of equity-driven tobacco control. We'll examine what's at stake, the impact of budget threats, and how we can galvanize momentum to protect progress. Today, I'm joined by an amazing group of panelists, Dr. Thomas, and excuse me if I, again, butcher your last name, Iliola, with the president and CEO of the North American Quitline Consortium, Lorraine Lantham, founder of Jump at the Sun Consulting, Sally Herndon, former head of the North Carolina Tobacco Prevention and Control Branch, and Sarah Wiley, manager of Oregon Tobacco Retail Licensing Program, along with Rod Liu, executive director for Appeal. Thank you all for joining us today. So I'm going to start today's conversation with Rod Liu, executive director of Appeal. I've had the privilege of working alongside Rod for nearly 20 years, and I can say without hesitation that his commitment to community-driven change is unmatched. I've learned from his leadership, been inspired by his vision, and witnessed the tangible impact he's made, not only within the Asian American, Native Hawaiian, and Pacific Islander communities, but across all communities targeted by the tobacco industry. His work shows us that meaningful change is built on deep relationships, cultural humility, and an unwavering dedication to justice. Rod, thank you so much for joining us today.
Thank you for having me and for that kind introduction.
So, as a leader of a national health organization, you bring unique perspectives to tobacco prevention and control. Can you share how your organization contributes to the national landscape of prevention and what role partnership play in strengthening this work?
Yeah, our organization, Appeal, Asian Pacific Partners for Empowerment, Advocacy, and Leadership, has as its mission to build community capacity around commercial tobacco control and other health disparity issues. So our organization helps to bring folks together as part of a network and then partner with other organizations doing tobacco control work. Through the partnership we've had over the past couple of decades, the partnership with CDC has been long lasting and sustaining. And it's been one of the most powerful partnerships for us and our communities. And it's sad to me to see all these cuts that are happening, partially because I recognize what the potential impact is and will be on our communities when those cuts happen. We will no longer have access to critical information. We will no longer have the ability to bring folks together on our networks and to be able to move this the efforts forward. It's also horrifying to see attacks on CDC, and our hearts go out to the family of Mr. Rose, who was killed during the attack a couple of weeks ago. This is the indication of how potentially negative this is going to be on all of our communities when this happens, is that we value the work that we do with CDC. We value public health. And when these things are threatened, then we really feel that we're going to be missing out. And one of the critical partnerships that exist within CDC are the national networks that are funded by CDC, 9 of them. And these national networks provide a unique resource to being able to tackle commercial tobacco control in some of the many communities that we have, and some of the many communities that have not been reached by other types of programs. And these national networks have the ability to not only serve communities, to be able to provide educational messages to their respective populations, but to contribute to the overall effort that's needed to combat tobacco industry and to fight for change that will result in positive health outcomes as it relates to tobacco control. I will say for the national networks that oftentimes for our communities, we're described as hard to reach communities. But when you actually look at it, that's the wrong term. The term that should be used is hardly reached. And our national networks have the ability to reach these hardly reached where other programs may not be as successful.
That is a really great distinction, hardly reached. So, when we think a little bit more about your organization's mission, how does it really connect to tobacco prevention and control? And what immediate impacts are you seeing from funding challenges at the federal level? Uh, in addition, if OSH funding, let's say, were reduced or eliminated, what would that mean for your work and the communities you serve?
Well, I think first of all, tobacco issues are very devastating for our communities. They result in millions of deaths that are preventable. And as has been described, it's the single most preventable cause of death. But tobacco control is also not the only health issue, nor is it the only way to address health disparities in our communities. And so we try to provide a holistic approach to incorporating tobacco prevention and control along with cancer prevention to be able to address multiple health issues. And there are so many different impacts that tobacco has on different health issues that just by addressing one, it helps to address many. So our approach is really to build that capacity of communities, and that takes time. It takes building trust over time. And what CDC has helped us to be able to do is to support that community capacity building over time so that we are at the place now where we're able to make some great impact on other things like the engagement in policy change, being able to create leadership to respond to these growing health disparity issues. And that's particularly important for the communities that we work with, Asian Americans, Native Hawaiians, and Pacific Islanders, which are actually two separate racial groups, because we're often overlooked as a group. And there's two reasons why that may actually be happening. One is that compared to other populations, we may be a slightly smaller population, even though our communities are some of the fastest growing groups in the country. The second is how data is presented. Because our communities are so diverse, the data is often lumped together and aggregated as one homogeneous group when actually we are a very heterogeneous group of many different communities. And it masks the high rates of smoking and tobacco use in certain particular populations, such as the Lao community, Cambodian community, Native Hawaiian community. And so CDC support allows us to be able to dig deep, to advocate for greater data on certain populations and be able to see the true picture of what's happening in our communities. Because if we don't, what will happen is we may be successful in other things, but we won't completely address the tobacco issue and get to what people are describing as the end game.
Great. So, looking ahead, if these cuts aren't reversed, what do you see as the most significant risk to tobacco control efforts nationwide?
Well, as I mentioned, I think the work that we do builds on previous work. And I think over the past decade, we've been very successful, not only in addressing tobacco control nationally, but being able to have some inroads in different states as well as working with different populations. It's not perfect, but we've been having some great successes. And if we were to have these cuts realized, all that progress will go out the door. We will lose the momentum that we have gained in being able to get to the place where our communities not only have positive health outcomes or more positive health outcomes, but have a role in determining how their health is going to turn out. So we really need to kind of keep this vigilance, not only against, the tobacco industry, which is a huge thing, but also being able to resource these programs to be able to keep the momentum and drive down prevalence of smoking in different communities, especially those that are hardly reached.
That is really such a great reminder, I think, for all of us to think about ensuring that our hardly reached communities are not being left behind through these devastating cuts and their impacts. Thank you so much, Rod. Let's actually widen the lens a little bit and bring in our full panel and talk a little bit more about some of the additional impacts that we're seeing. So I would like to open up this first question for everyone. What immediate impacts of OSH cuts are you seeing or anticipating? So let's start with Lorraine.
Thank you. So I am responsible for implementing the Wisconsin African American Tobacco Prevention Network as well as the Poverty Network. And I would say for the moment, our networks have not experienced any immediate impacts as a result of the OSH cuts. We're funded by the state. And I can say our state's tobacco prevention and cessation program, their budget in terms of CDC funding was cut by $1.5 million. And what that has meant to them is kind of a restructuring. They had 9 positions that were funded through CDC. One of those positions they won't be filling, and the other the other 8 positions, they had to find funding to continue to fund those programs. So again, there was a vacancy, but other losses that I can say that we've seen is in terms of less funding for paid media campaigns to promote our cessation or quit line programs, paid media awareness campaigns at the state level. And the federal level, we are anticipating cuts as it relates to the paid media around tips from a former smoker. We also are anticipating cuts as it relates to training ours that work in low-income communities, and also the ability for our cancer centers to offer referrals to the quit line as well. So those are just a few as it relates kind of broadly speaking.
Thomas, from your perspective.
Yeah, first let me thank the campaign for inviting me to represent the North American Quitline Consortium on this panel. What I see as the most immediate impact has been the loss of a central point of information. If you think of all state commercial tobacco programs as part of a wheel, we're missing the hub, and that really destabilizes the system. So in the absence of federal leadership and coordination, we've seen rumors, both factual and not factual, circulate really quite quickly. That causes uncertainty, it causes chaos, sometimes panic, and that increases the stress for our public health workforce at both the state and local level. Another critical function has been the funding, maintaining a floor of funding for state programs, as Lorraine mentioned, specifically for tobacco cessation quit lines. We're watching a handful of states really closely as to whether they'll even be able to maintain their services without federal funding. As soon as we saw the OSH funding for states, when it was not renewed at the end of April, we saw several quit lines reduce services to a minimum. For example, they cut free NRT, or maybe they were only able to offer 1 or 2 coaching calls. Some had to trim special protocols, such as those for people with behavioral health conditions. And ultimately, the impact is that fewer people will quit and more people will die from tobacco-related diseases because we're missing or have reduced the availability and effectiveness of support to help them with quitting.
This common theme, it seems so far, is the most impacted and the most underserved are going to be the most impacted. Sarah, what are you seeing in Oregon?
Yeah, thank you. And thanks so much for having me here today. So at the Oregon Health Authority, I think we're really lucky to have state funding sources to maintain the essential parts of that tobacco control program in the absence of the Office on Smoking and Health. And we certainly don't take that for granted. I think the changes that Lorraine spoke to are very real across the country. What I am really seeing is that without the CDC Office on Smoking and Health, we're really losing that unifying network that allowed for easy connections with other people who were doing commercial tobacco prevention work. So every time I'm reaching out to colleagues in other states or in CDC-funded organizations, I'm dreading getting an email bounce back telling me that the program or the person are no longer a part of that program, or no longer working there. So I think at best, the OSH cuts are disrupting what has really been an incredible network of public health and community connections. And at worst, I think that wealth of knowledge and dedication is being gutted.
Let's end it with Sally. Sally, what immediate impacts of OSH cuts are you really seeing or anticipating in North Carolina? I mean, you directly have been impacted.
Yes, and thank you so much for having me. I want to say that since I am retired, I'm speaking for myself and my experience and not for my organization, which was the Department of Health and Human Services in the leading tobacco producing state in the nation. And I'm really sad to report, and a little bit angry, honestly, to report that all 9 state level staff have been let go in North Carolina. These include people who have the skill sets that CDC best practices has always recommended, including subject matter experts in policy, media, surveillance and evaluation, budget, administration, and building partnerships and sustainable infrastructures. These folks were deeply committed, and the people that remain in North Carolina public health are really feeling this loss. Only 2 full-time staff remain. These focus on tobacco prevention and cessation and are funded by dual settlement dollars, which is scope and time limited in North Carolina. The Division of Public Health, the good news is that they were able to switch funding for our regional managers in our 10 public health regions to the dual settlement funds. And so they remain on board, but again, are scope limited to working on tobacco prevention and cessation among young people. Across the U.S., CDC has provided a no-cost extension, and so other states are faced with losing staff, as you have heard before, and we're really missing the hub, which is OSH, in our states because they kept us all together. We know that it takes people power from folks with skills and people to train new folks with skills and time to apply those things. And OSH had all those skills to help build sustainable capacity across the United States.
Which is just so unfortunate, and I know it impacts us all. So when we start to think a little bit more about the disproportionate harms, I want to throw this next question over to Lorraine. How are historically marginalized communities being disproportionately affected by these funding reductions? So Lorraine, why don't you jump in first, and then I'll pass the same question over to Sarah.
Sure. I would say that, again, marginalized communities have always been the ones to have less access to information and services. Basically, when you defund support, we disconnect patients from information and care. So it's always been difficult to get our community to access cessation programs. I think it makes it that much more difficult. When I think about our federally qualifying health centers, that are in low income communities. Those are centers that our state has in the past provided training and funding, basically training to help them support people in their cessation journeys. And I feel like there's going to be less of that training going on, less of that information disseminated. And then also just looking at marketing in our state, the tobacco industry spends $160.2 million in the state of Wisconsin to market their programs, to their products. And most of that marketing occurs in low-income communities of color. So again, with these cuts, with fewer dollars to counter that marketing, it's going to have an impact on Black health and health of people, of low-income people as well. So again, less resources to do the important work that needs to be done in marginalized communities.
Sarah, same question.
Yeah. So from where I sit, I think CDC OSH really provided that unifying framework and focus for eliminating commercial tobacco caused inequities. So CDC required every state to focus on communities that had been left behind that hadn't benefited from progress that we've seen nationally. So for example, here in Oregon, we used CDC funding to build better cessation options for people living with behavioral health conditions. We supported culture prevention strategies in Oregon's urban Indian communities. And I think some states might be able to sustain funding for these initiatives. We're certainly trying to, albeit in a more limited way as those grants sunset. But I think by focusing on marginalized communities nationwide, each state or community-based organization was really able to build on the learnings and the progress that was happening next door. And so without OSH, I think that process is going to become more fragmented. And I'll also add that OSH allowed for some flexibility in how each state worked, but the structure was really just rigid enough so that no program could ignore inequities that still exist in commercial tobacco work. So each state has a really unique culture, leadership structure, and history with tobacco prevention. And those requirements at the federal level really ensure that equity-focused work is prioritized across all states. And I think just to conclude, from my role in the Tobacco Control Network Executive Committee, I've seen states adapt to these cuts in different ways, whether that's fewer staff, contracts, or grants. But all of those cuts really diminishes the collective progress and exacerbates inequities that have been caused by commercial tobacco.
When we think a little bit about what culturally tailored approaches or community-specific programs are at risk because of these funding cuts, I want to turn it over to Sally first, and then I want to go back to Lorraine. Let's dive a little bit deeper there. So what programs really are at risk, Sally?
Okay, so diving a little bit deeper from what you heard from Lorraine and Sarah, evidence-based approaches are at risk with these cuts. What I know that we know works is to advance health equity by identifying and eliminating commercial tobacco product related inequities and disparities. And let me just unpack that because that's kind of a mouthful. We talk about commercial tobacco products to distinguish them from the use of sacred tobacco that is considered important to many tribal nations in the United States. Inequities are systemic, unjust, and often actionable. Think about preemption, for example. They're often associated with an imbalance of power. Think big tobacco contributing billions to campaigns to prevent good policies from going into place, or the loss of funds from counter marketing, as you've heard before. And then disparities are health differences that are closely linked to social, economic, or environmental disadvantages. So think of that bottom part of the pyramid and trying to help everybody have access to health in an equitable way in the United States. So states were asked, as you've heard from Sarah, to use CDC funds for these purposes. And we were all working to advance health equity by eliminating a huge inequity, which is that behavioral health facilities allowed tobacco use and did not treat tobacco dependence concurrently with substance use disorder and mental health programs. And this is a huge cost to our nation and a huge oversight in how these services are delivered. And all of us were working on that in North Carolina. We were really on track to make that happen until these cuts happened, and now it's been delayed. We were also all working to advance health equity in e-cigarette use among youth and young adults, because as you know, if you have a child or a grandchild in your family, e-cigarettes are all over the place, as are all kinds of unregulated products that you can get in vape shops and other retail marketing places. And like Sarah said, there was some flexibility in CDC's funding. And in North Carolina, we chose to advance health equity with active duty military. Fort Bragg in North Carolina is the largest military base in the world. And there was huge history and context with smoke 'em if you got 'em. I mean, a lot of the addiction to this horrible product happened when cigarettes were given away to military folks during wars, and then they brought it back to their families. So we were really fortunate to get to work for a while, but that funding has ended. That we're working with Fort Bragg to provide tobacco treatment as a part of services there to get them ready for the work that they were going to do as active duty military, and to do so in a tobacco free environment on base. It was so bad at Fort Bragg that a lot of people came there smoke free from base camp, and then they started smoking because it was so normative when they got there. I'll also add that North Carolina was also fortunate to use other CDC COVID health equity funds to identify and eliminate commercial tobacco product related disparities among North Carolina American Indian tribes and LGBTQ communities, and really build strong partnerships. And all of these things saved lives and saved money.
So Lorraine, same question. What are some things within Wisconsin that you've been seeing?
I think for us, the two biggest areas is our work that we've been doing with menthol. The state really supported our networks and put CDC funding into us and the work that we do to raise awareness around menthol. We know that African Americans, 9 out of 10 African Americans are more likely to smoke mentholated tobacco products. So we did a lot of work and energy has been put into the menthol efforts here in our state. Even with our quit line, if people would call and they smoked mentholated tobacco products, they would be given more in our TPs as well. And so I just think that work it's stalled. It's not moving. We developed a social media campaign around menthols as well. And then the other area, still related to evidence-based cessation programs. There are so few evidence-based programs specifically tailored for African Americans. We're just not kept in mind. And we know that evidence-based programs work. So we've been working with the University of Wisconsin, the Center for Tobacco Research Intervention, to design a program specifically tailored for African Americans. Normally, this is work that would be done in collaboration and support of our state's tobacco prevention and cessation program. So for me, I think some of the things that might be lost, that is, once we get this evidence-based program in place, it may be difficult for us to take it to scale so that African Americans throughout our state can benefit from what is truly missing in terms of tailored programs for African Americans. So the two big things for us are our menthol work and efforts, as well as evidence-based cessation programs.
So let's dive a little bit more into cessation programs. We've heard a little bit about the through lines of the importance of cessation services and some programs that are at risk. So what are some of the implications of reducing staffing or capacity for services like quit lines and other cessation programs? Let's start with Thomas.
Yeah, when we think about quit lines and cessation programs, we can think about it in terms of the famous public health impact equation. That is that reach times effectiveness equals impact. So with reduced budgets, some states will struggle with reaching people with services that are effective, like telephone counseling that is available from quit lines. So even if they have effective services, they probably are going to have less money to educate the public about the benefits of quitting and the availability of resources, and that's the reach side of the equation. The CDC TIPS campaign is in its last year, unless Congress decides to add to the budget, which means millions of people without the TIPS campaign will not learn about their quit line through mass media communication. More importantly, though, we have to look at who is impacted when you have less money. States will be under enormous pressure to simplify their communication strategies to reach the broadest audience possible. And that ultimately means our priority populations, especially those that are small in number, are less likely to have messages that are intended specifically for them. And I've seen these conversations happen live. When I first started working in tobacco control, I worked with high risk and often street involved youth in a community-based organization. You know, not surprisingly, smoking rates, this was about 20 years ago or so, smoking rates then were near 85%. They would have other risky behaviors that would go along with it, like picking butts off the street and then using the butts from the butt tobacco, either smoking it or rolling into unfiltered cigarettes. And I was at a conference about with kind of doing strategic planning to figure out how we were going to address multiple populations for prevention and control. And I happened to be seated next to the representative for the ad agency that was promoting the quit line and other prevention messages. And I was explaining about the population that I work with and what their needs are and the programs that we were doing. And of course, this person was very impressed and thought it was wonderful work, really mission-driven work. That's why we were doing the work. And while they appreciated it, what they told me was, well, we'll never reach that population with our ads. And just like that, wrote off the most vulnerable group of people who needed the most help. And that's what really concerns me in this current environment, is that when we reduce resources, it's the people who need the help the most vulnerable people who are the least likely to then be reached.
And Sally, North Carolina, primary tobacco state.
Yeah. In North Carolina, since we've lost all of our CDC funding, our staffing for quit line NC will use state funds to fund a director of cessation that's now posted with the CDC Foundation. The North Carolina General Assembly would have to approve a state-funded position. This may happen in the future, but with the speed of the furloughs and the RIFs, we weren't able to make that happen. As you heard from Thomas, Tips from Former Smokers, a very effective campaign is ending sometime this fall, as far as we know. And I would like to see that campaign continue and even continue year round. We invested some dollars in it in the months that CDC wasn't funding it, and we found that it made a difference, even in those months with limited dollars. North Carolina wasn't fully able to meet the demand, and we really prioritized based on those people at higher risk, especially low income and uninsured. And with the national cuts to the federal Medicaid program, even more folks are going to be uninsured. North Carolina had finally expanded Medicaid, and now we're losing those dollars. And that will increase healthcare costs across the board. These impacts on promotion of cessation and service delivery, especially among historically marginalized populations, low income populations, and as Rod said earlier, those hardly reached will result in fewer people successfully quitting, more people becoming sick or disabled due to tobacco use. Right now, for every death, 30 more people are sick or disabled, and I imagine that number is going to go up.
Man, that's always difficult to hear. So, Sarah, let's talk about some of the strategies you and your organization are using to maintain services or kind of shifting some priorities in light of the reduced funding. And then I'd like to ask the same question of you, Thomas, as well. So, Sarah?
So I think that there's short-term answers, and then there's also going to have to be long-term approaches. So as Sally referenced, in the short term, we're really shifting some of that more flexible funding to cover staff and essential services that had been funded by OSH. So what are those CDC-funded strategies that can be supported by the Juul settlement instead of federal funding? And then I think we're also asking ourselves the question, what goes away entirely? What work just disappears if our program cuts funding? So that might mean asking or ensuring Medicaid pay more for cessation and quit lines so that our program on the public health side can prioritize funding for community-based organizations that have less resilient funding streams. And in Oregon, we also have a tobacco tax that is at an effective level. We receive some of that funding, but that effective tobacco tax is leading to reductions in tobacco use. So in turn, that means reductions in state revenue for the program that we have to adjust for. And I think what that goes to show is that this long-tested, effective public policy, is an important tool in our tobacco prevention and control efforts. And we're hoping that that progress will long outlive the current funding challenges. So in the long term, then, we also have to do work that reaches a broader audience with less funding. So there are exploratory projects we funded at a small scale, for example, for behavioral health, that we're hoping to broaden across the state. And then to do that long-term work, we really have to retain as many of the state program staff as possible. It's kind of an interesting flip that in the last 10 to 15 years, a lot of the funding shortfalls that our state program experienced mostly hit at the state level. And so Oregon could depend on CDC to keep those essential quit services, media campaigns, and data collection going. But now that's reversed, right? We have state funding, but we've lost all of that national support. And it's really hard to retain staff while also keeping our commitments to community-based organizations. But we're not going to be able to maintain any support for Oregon's communities without people who can actually do the work. So I think that staff piece is really critical as we move forward as well.
Thomas, same question. What strategies is the Quit Line or the North American Quit Line Consortium doing or using to maintain services or help shift priorities?
Yeah, so the North American Quit Line Consortium is a small organization, so we're very nimble. We don't deliver the direct services. We're a member organization that helps to coordinate and maintain some of those best practices around cessation programs. But I can speak to the larger cessation system shifts. I spoke earlier about reach, so I'll talk now about the effectiveness side of the impact equation. And there's several cessation strategies that we know work, things like counseling, medications, digital programs like web and text. There's a couple of apps that are showing promise, and we know that artificial intelligence, AI, is coming for all health services. Counseling remains the most effective single modality for treating tobacco use and dependence, whether it's in groups or classes, individual, in person, or over the phone. And this is NAC's, I'm going to use the acronym NAC, number one recommendation for states with low resource environments. That is, maintain your telephone counseling services so that the most vulnerable populations still have access to that type of support. Cessation medications are often covered by insurance, so state systems can focus on uninsured or underinsured groups. There's free evidence-based digital programs available through smokefree.gov or through other free services like the Truth Initiatives programs. And so it's important for us to see cessation as an ecosystem of all of these different treatment modalities and different providers. And we want to remove as many barriers as possible, especially those that are related to cost and availability or accessibility. And this is what Quit Lines have really excelled at doing over the past 20 years. And we want to preserve those evidence-based services as much as possible. In some states, that will mean reducing eligibility for services to focus on those who are most vulnerable. It may mean reducing the amount of services offered in order to provide at least some service. For example, 1 or 2 coaching calls that have a small impact but are still evidence-based. Ultimately, as services are reduced because of budget cuts, it means less effectiveness for services overall. And then again, when you combine that with the headwinds that we're facing on trying to get reach with these programs, it means we're unfortunately looking at decreases on both sides of that equation. And that the result will be that people are needlessly exposed to the tobacco industry's predatory practices, that people will needlessly develop preventable smoking-caused diseases, and people will die without having these services.
So, just speaking to the importance of these services, we've heard how vital they are. These evidence-based services are really creating such an impact, helping the most impacted be reached and supporting their quit journeys. What can national organizations or partners or individuals, what can we do to help advocate for the restoration of OSH funding and long-term investments in equity-focused programs? Thomas, I want to turn that back to you. And then Sally, would love to hear your perspective as well.
Sure, yeah, I'm happy to start addressing that. I actually don't think it's going to be the national networks and national partners who are going to be able to do this work alone. I think this one's going to take all of us. It's a whole of society approach. Certainly we need those national partners speaking with, congressional and Senate aides, members of Congress, senators, and those conversations have an impact. We've seen that in the most recent appropriations bill coming out of the Senate committee, that we know that those conversations work. They can get in their ear and they can encourage funding. But government responds to people, and that means that all of us has a role. It means every one of us can call our representatives. We can tell them that we want them to focus on tobacco control and continue that funding. It means that we need to reorganize at the grassroots, reforming, reigniting those local coalitions who push their city councils, who push their states, who push the federal government to act. That's how we got where we are today. And we can't lose sight of the fact that everyone who's tuned into this conversation today has a role to play in moving the conversation forward.
Sally, same question.
I agree with Thomas 100%. And one of the ways we can do that is to really understand what your decision makers' context is for making those decisions, and speak out about how comprehensive tobacco programs save lives and save dollars. Some people that are not moved by health and improving health may be moved by saving dollars, for example. You've heard earlier that for every dollar invested, states can save $55, mostly in healthcare costs. And for businesses, there's even a greater savings in reducing lost productivity. So in terms of those coalitions that you're bringing together that Thomas mentioned, one of the groups that we've brought forward are businesses. In fact, North Carolina is really known for furniture manufacturing. It's one of our biggest industries. And I want to give a shout out to Rock House Family of Brands. They are a big furniture company in North Carolina. And they invested in the quitline services. So their people in their industry would not have to suffer any loss in services from quitline and C if we were cut. So they did it once. It was so successful. They have re-upped again and are continuing with that private partnership. And we're really pleased about that. I also agree that none of us can do this alone. And one of the wonderful partnerships I've been fortunate to work with, and still am as a retired person, is the Duke UNC Tobacco Treatment Specialist Training Program. This is the only tobacco treatment specialist training program that wraps clinical training for how to treat tobacco dependence with public health, community, media, policy, and program services. And we held it 3 times each year. And our national networks are just fabulous at talking about what work they do in terms of reaching hardly reached populations, as you heard earlier. And I'll put a link to that in the chat if you're interested. So I just want to commend them. And I also commend the national networks who are working hard to diversify their funding without falling into the traps where there are conflicts of interest. And we can all learn from this.
Just again, so important, especially now, to look at how we are leveraging community partnerships and what we can do individually to help elevate our voices in support of these national networks, of these tobacco control programs that truly are saving lives. So I want to hear a little bit from Lorraine. We've done a lot of work supporting young people and a lot of youth-focused work collaboratively together. So I want to hear from you, how can we maintain or strengthen youth-focused prevention efforts, especially when communities targeted by, especially in communities targeted by the tobacco industry, especially now. So Lorraine, and then I would love to hear from Oregon, what you guys are doing as well.
Thank you. Well, I think it's a wonderful thing in terms of young people. They're interested in advocating for issues that impact them, that affect them. So it's important, I think, for us to create room for young people and their voices to be heard and for them to lead. This is an excellent issue for them. In Wisconsin, we have our FACT program, and that's made up of young people that they engage in peer-to-peer education with other youth. They educate themselves on the issues. They speak to our elected officials, both our state legislators as well as in DC. And they've brought about change. They've brought about change here locally. They've increased the fines that retailers pay for selling to minors. So I think for me, it's important for us to continue to keep youth engaged, involved, and in leadership roles.
Oh, great. Sarah.
Yeah, so I think this is going to look very different in every state and for every organization. At the state program, it's no surprise that state government isn't exactly known for being hip and running youth groups. So I think that, the question is really how we use statewide reach and tools we have to support organizations like Lorraine's that are better equipped for that work. And so I think one of the best ways to spark that connection is by supporting community with the data that we have. And so, for example, part of my role is managing our state's tobacco retail license program. We're kind of unique in having that function in a public health program. Our inspectors have good relationships with retailers, and they're also seeing that tobacco industry innovation in the field. So they're seeing the video game vapes. Our program is getting the complaints from the firefighters that are getting unsolicited shipments of the next generation smokeless products. Our staff are the ones getting questions about people who want better protection from secondhand smoke in their homes and aren't sure how to do that. And we also work with local public health authorities throughout the state to assess the retail environment and look at product availability and promotion. And so we have all these stories, we hear these things, and it really helps us, I think, to understand community need and also illustrate what the tobacco industry is doing in a very tangible way. And so at the state level, I think our unique contribution is making those stories and the quantitative data accessible to organizations working locally so they can really pair it with their own experience and advocate for what their community needs. I think there's also an opportunity to work more on shared risk and protective factors. So for example, collaborating on community building, job development programs, working on e-cigarette waste disposal with the state environmental agency, which we're starting to do. And so if we keep moving upstream with those organizations and agencies that have similar goals, then I think we can keep some of that momentum going on the critical work that has to happen, even with reduced resources.
So I want to open this next question as we come towards the end of today's conversation. What gives you hope, and what is one action each of us can take right now to protect progress in tobacco control? Understanding this current climate, really where we are, it's important that we are visioning towards the future. So with this, I would like to start with Rod.
Yeah, this has been a wonderful conversation. Thank you so much. I just think that everybody has mentioned marginalized communities and has recognized that when cuts happen, those most impacted are going to be the most marginalized. But I also agree with what Thomas said, which was that we can't expect national networks or vulnerable communities to be the only ones fighting. In actuality, in an environment where those who speak loudest get funding, we need to rethink how we are looking at marginalized communities and whether the work that we are doing is really prioritizing not only programs for groups like national networks, but for imagining what the next generation of tobacco control leadership is going to look like. It should look like coming from our marginalized communities. And we have models of community leadership development like the LAMP Leadership Institute in Minnesota, originally funded by Clearway, Minnesota, to build the next generation of leadership in tobacco control. And so that's both a hope and a thing for us to really think about, particularly those of us who are doing tobacco control, is really reassessing how we are using our funds and whether it's actually getting, as I mentioned before, to those that are hardly reached. Thank you.
Sarah.
I think, as always, with this panel and with others, for me right now, it's about resilience. The prevention community is, I think, collectively recommitting itself to this movement. And so I think in terms of action, I think where we are is that we can really think about what it's time to let go of in this movement, and then also what opportunities are opening up as we start to rebuild. So I think that's where I'm trying to take my my inspiration these days.
Been a difficult kind of through line is we've been having to make difficult decisions on really what to let go, which in turn really makes us really focus on what's the most impactful and how are we really setting up this next generation to really take the lead as well. Lorraine.
Okay. I think what gives me hope, and I'm talking about immediate, like what gives me hope is related to our advocacy partners that are in the trenches fighting the good fight in terms of American Heart, Lung Cancer, and the African American Tobacco Control Leadership Group. That gives me hope. They give me hope. And I guess for me, looking at OMB and the fact that they've frozen funds, that would support the tobacco work that we do. I would encourage everyone that's watching this particular webinar to reach out, and I say reach out to Republicans that have been champions, and really educate and encourage them. Republicans, kind of governors at the state level, educate them, hopefully for them to, I'm being very specific, but for them to reverse the freeze that OMB has on CDC funding at this point. I'm sorry that I'm being so specific, but that's where my mind and heart is right now in terms of those funds that are available and should go out to states. So that would be my wish for today.
Thomas?
Yeah, as the initial shock of the last 6 months in commercial tobacco control begins to wear off, we're really seeing people begin to start asking how we're going to move forward. And I take hope in knowing that people are not sitting unable to move. They are planning for the future, and they're starting to take those small steps to get there. You know, the future is always uncertain, and these days it can often feel pretty bleak. But we have incredible fighters among us, and I think tobacco control attracts people who are ready to take on powerful interests. We've been pushed back, we're not defeated, and we're going to make sure that people who are vulnerable get the help that they deserve. An action that every one of us can do is speak with your political representatives about the importance of tobacco control work, because they are listening.
And Sally.
Well, all of you on this panel give me hope, and Campaign for Tobacco-Free Kids gives me hope, and thank you all who are joining in this call. You give me hope for being here. One of the things I am pleased to see is the recent Senate Appropriations Committee vote that restored 246.5 million in this budget um, to the CDC Office on Smoking and Health, but it's just the first step. That was the Appropriations Committee. I am pleased, like Lorraine was saying, that it had strong bipartisan support, and we have more to go. So, like everybody is saying, contact your senator and your representative, understand where they're coming from, and tell personal stories. It's really important. I mean, I lost my mother to tobacco-related disease. Lost my younger sister to secondhand smoke caused lung cancer. She never smoked a day in her life, but she died from lung cancer. So tell those stories. If you haven't seen the Vimeo of the congressional briefing that was led by Dr. Brian King from Campaign for Tobacco-Free Kids, we'll put it in the chat so that you can see it. It was really good, and there are great talking points for you to use. I was really honored to be a part of that panel that also included a Tips from Former Smokers spokesperson and a young person, and young people give me hope. So thanks, Lorraine, for bringing that up. And of course, Campaign for Tobacco-Free Kids, your regional representative can help you learn how to talk with your legislators. And I'm a free agent now, so if you want my advice about that, I'd be happy to talk to you too. Thanks.
Love that. So today we've been clear. Funding for tobacco prevention and control isn't just a budget decision. It's a public health setback with life and death consequences. Without these programs, states lose the only dedicated federal funding for tobacco prevention and cessation. Quit lines scale back or close. Proven campaigns like Tips for Former Smokers go silent. Surveillance weakens just as e-cigarettes and other nicotine products keep evolving and end up in our communities all across the country. The result? More kids start, fewer people quit, and health inequities deepen. As Sally mentioned, we've also seen the power of advocacy. On August 1st, the Senate Appropriations Committee voted 26-3 to preserve OSH funding and other CDC prevention programs. A strong bipartisan signal that these investments matter. That vote happened because people like you spoke up. Now the fight moves to the full Senate, the House, and the administration. And this is where we cannot afford to go silent. Every panelist today has shown us that culturally grounded programs work. Equity matters, and prevention saves both lives and money. Up to $55 in healthcare savings for every dollar spent. So here's the call to action. Share these stories within your networks, within your media, and directly with your policymakers. It's important to elevate your voice now more than ever and let them know how important these programs are for you, your community, and those hardly reached. Lift up local impact. Make sure it's clear how OSH funding sustains real programs in real communities. And share we're going to share in the chat how states' impact of the loss of federal funding for tobacco prevention and control and how you could engage and raise your voice. And more importantly, mobilize now. Now more than ever, we need calls, letters, op-eds, social posts, so decision makers know these programs are essential. Utilize our action alert to contact your members of Congress. Again, this should be scrolling at the bottom of the screen. We know what works, we know what's at stake, and we have momentum, but only if we act. Protecting funding for tobacco prevention and control is protecting lives, protecting equity, and protecting the future. Let's make sure Congress finishes the job. Thank you all for joining us today, and thank you to each of our panelists for elevating your voice on this vital issue today. Thank you again for joining another cultural conversation with the Campaign for Tobacco-Free Kids.